every molecule of hemoglobin binds with 4 molecules of oxygen. We've talked about that before, we knew that. And we need to spend a little bit of time talking about the oxygen-hemoglobin dissociation curve. Okay? Oxygen-hemoglobin dissociation curve. So this graph shows us the oxygen-hemoglobin dissociation curve. If you look on the x-axis, these are PO2s. The y-axis is showing us the percent of hemoglobin saturation, right? Oxyhemoglobin saturation. So we just learned that a normal PO2 for our arterial blood is 100. So let's go check at a PO2 of 100, how saturated is our hemoglobin? Oh, what a surprise. It's 100% saturated. Kind of what we would expect, right? So the blood has just gone to the lungs, it's come back. The hemoglobin's 100% saturated at a PO2 of 100. We also just learned that when we go out to the tissues, we of course dump off oxygen, and we learned that the PO2 drops to 40. So let's check our saturation at a PO2 of 40, and we come up here, look at this, 75%, right? So we're at 75% saturation. That's odd. Do you see what this graph is telling us? That in a normal route through the body, we go out to the tissues, we dump out oxygen, the venous blood coming back is still 75% saturated with oxygen. We've only dropped off 1 of the oxygen molecules of the 4 that are on the hemoglobin. So 1 of them came off readily, and that's all we gave up. That means we have 3 left on our hemoglobin in reserve, so that if we need it, we've got it. Something else that this curve shows us is beyond a PO2 of 40, look at the change in the shape of the curve. So here where that first molecule came off. Now when the PO2 drops less than 40, look at the curve. It's incredibly steep. So that our hemoglobin is made such that if the PO2 starts to get less than 40, the oxygen comes off very quickly. Right? So as PO2s drop, oxygen comes off the hemoglobin very quickly. The next 2 very, very easily, and the third one, the fourth one a little bit harder, but for a small PO2 drop here, we dump off a bunch of oxygen. So you start to exercise. All of a sudden the tissues are using a lot of oxygen. The partial pressure in that tissue is going to drop, and the hemoglobin will start to drop off more oxygen as needed. Right? So we're carrying this reserve on our hemoglobin, and when you need more oxygen, the PO2 in the tissues drops because you're using the oxygen, the curve gets steep, and hemoglobin readily unloads. There are other factors that affect the unloading of the hemoglobin more than we're going to get into in this class. Temperature has an effect as well, but one of them that is important to us is the effect of pH. So if you start exercising, you're going to start to produce carbon dioxide, and of course carbon dioxide, we're going to learn in a minute, associated with the increased CO2 will be increased acid. So the pH starts to drop in the tissue, also due to lactic acid that we've talked about. And as that pH drops, so the normal blood pH is 7.4, the center part of this curve. As the pH starts to drop over to the 7.2 in this case, you can see that we will unload more oxygen than we would have normally at that same PO2. In other words, as acid levels increase, the hemoglobin gives up the oxygen even more readily, which should make some sense to you, right? So you're using the tissues, they're producing lactic acid, and you're getting hydrogen ion. Let's dump even more oxygen. Emily?
So you're saying instead of just dropping off 1 of the oxygen molecules, there's going to be more?
Yeah, so look, let's go to PO 240 again. Here we were at the normal blood pH, 75%. But look, if the pH has dropped to 7.2, look what's happened. We've come down on our saturation, right? So we've started to drop off the next one, simply because of trying to get more oxygen into the tissue because the pH has dropped. Okay, and then finally here under oxygen I have carbon monoxide poisoning. Okay. Carbon monoxide poisoning. You're all familiar with the concept of carbon monoxide poisoning, but we should spend a few minutes talking about it. Carbon monoxide.
I'm sorry. So you said increased CO2 equals, it increases the pH?
It lowers the pH.
Oh, lowers
increases hydrogen, lowers pH.
Increases hydrogen. Thank you.
So carbon monoxide is odorless and colorless, and it's produced when you have only partial combustion of molecules. Because it's odorless and it's colorless, it's very dangerous. Dangerous? No. Dangerous. Right? Carbon monoxide binds to the hemoglobin at the same site as the oxygen binds. But when it binds to the hemoglobin, it binds and has a stronger chemical bond than does oxygen. So it tends not to let go of the hemoglobin like oxygen normally would. So when you're exposed to carbon monoxide, the carbon monoxide is going to tend to stick to the hemoglobin, and it will then block oxygen from attaching. The other thing that's kind of unique about this, do you remember we talked about the color change between oxyhemoglobin and deoxygenated hemoglobin? When carbon monoxide is attached to hemoglobin, it causes the same color shift in hemoglobin as oxygen. And so the blood will still appear to be bright red, even though the person's not carrying adequate amounts of oxygen. These days in California, you're required to have a carbon monoxide detector in your home, right? All homes are required. It didn't used to be that way. And again, very, very dangerous gas. So I'll give you a couple of carbon monoxide stories, two of them from this area that I've seen over my years that I've been here. One of these happened in Salinas, the other one happened in Castroville years ago. In both cases, the carbon monoxide poisoning involved Hispanic families that didn't have much money. It was winter time. The first one, very interesting, in Salinas, the neighbors noticed that the family wasn't coming and going. They called police. Police came and everybody was in their bed and they were all dead. So what the earth happened here, right? They couldn't figure out why these people died. Did they get food poisoning? What's going on? Well, in the house was a barbecue, but by the time, of course, they found it, the ashes were completely cold. And what they eventually figured out is that it was middle of winter, it was cold, the family had had a barbecue outside, and after they were done with the barbecue, they said, well, it's cold outside, let's bring the barbecue inside and it will heat the house. Makes perfect sense, right? Except briquettes produce large quantities of carbon monoxide. So the family had been killed by the presence of the coals in the house. Similar situation occurred in Castroville 15 years ago or so. Other carbon monoxide stories you've probably heard about, right? So it was a number of years ago, but this one was really sad. A Boy Scout troop on the East Coast went camping in the snow, and they had brought a kerosene heater, and they brought the kerosene heater inside the tent. You would hope the Boy Scouts would know better, right? Kerosene heaters produce carbon monoxide, enclosed space, right? The Boy Scouts died of the carbon monoxide poisoning. Another one, Southern California, a number of years ago, a family, it was a cold morning. It happened to be a Sunday. The father got up early and said, well, gosh, I'll go out and warm the car up so when we get in it won't be cold. He left the door open between the garage and the house. Everybody found dead in the house, right? He was dressed. Nobody else had gotten up and dressed yet. Anyway, odorless, colorless. You should have a carbon monoxide detector in your house. It's required by law. Hopefully you do. Yes?
How long does it take?
So, so the question is, how long does it take? It really depends on how much normal air, good air you're getting in, and the carbon monoxide. So it varies. There's no easy answer to that question, right? Varies dramatically. If you find somebody that you suspect has had carbon monoxide poisoning, get them outside. Certainly do artificial respiration, but you need to call 911 because the only thing that's really going to save them is administration of pure oxygen, right? They need pure oxygen to be saved. Yes?
You're not going to be sucking in that CO2 when you're giving out?
You'll get small amounts of CO, but it's tiny. You're out on the outside, it's fine. I have one more story of carbon monoxide, but years ago we had a biology instructor here, nice lady, she's now deceased, but she started calling in sick. She said, oh God, I feel awful. I just can't come into work. I'm having headaches, I feel awful. This went on for quite a while. She eventually started going to the doctor, trying to figure out why she was feeling so badly. The doctor couldn't really figure out what was going on, but she noticed that when she was away from her house, she felt better than when she went back to her house. Of course, when she was ill, she was spending all her time in the house. Eventually, she figured out that it was carbon monoxide poisoning. She called a furnace company, and they found that the vent for her furnace had become plugged up. And so every time the furnace ran, it was accumulating carbon monoxide in her house. Yes?
What if they covered their vents?
Same thing.
Same thing.
Right? Carbon monoxide will accumulate inside the house. So,
Thank you.
odorless, colorless gas. I'll tell you one more. You don't have time for this to watch a movie now because you're taking my class. But when you're done with the class, a very old movie called Coma. Worthwhile movie. Any of you ever seen this? Oh, see, it's too old. People haven't watched this movie. See if you can find a copy of it somewhere out there. In the movie, people are going into a hospital to have, I don't want to ruin the story for you, but I'll ruin it anyway. They're going into a hospital to have elective surgeries done, and quite a few of the patients never come out of the surgery. They die, and they can't figure out what's going on. Well, eventually they find out that they're harvesting these young people's organs, right, to sell. And the way that they're killing them is that they have switched the oxygen line to the operating rooms out into a carbon monoxide tank. And so the patient is breathing the carbon monoxide, the surgeon's working, and the blood, when they're cutting, looks beautiful. It's nice and red, we've got great oxygenation. And then the anesthesiologist saying, oh, I'm starting to see irregular heartbeats here. And the surgeon said, well, are they getting plenty of oxygen? And then they wake up dead. Anyway, if you get a chance, you don't have time now, but watch the movie Coma. It plays on that other part of anesthesia where people are going under anesthesia. There's always that worry that I may not come out of the anesthesia. So it plays on that kind of built-in fear. Anyway.
Isn't that a Robin Cook novel?
What's that?
It's based on a Robin Cook novel.
It's based on Robin Cook, absolutely, who was a physiologist before he became an author.
At Mass General Hospital.
Yeah, I didn't know her. Carbon dioxide, how do we transport CO2? It turns out there are 3 different ways to transport carbon dioxide. One of them is attached to hemoglobin at a different site called Carbaminohemoglobin. About 20% of your CO2 is transported that way. About 10% transported in your plasma. Because CO2 is pretty soluble, it can be transported in the plasma. So if I had 20 and 10, I only come up with 30%. I'm missing a huge proportion of how we transport carbon dioxide. It turns out that 70% of our carbon dioxide is transported as the bicarbonate ion. Okay? So it's transported as the bicarbonate ion, HCO3 minus. And the way that that works is that carbon dioxide can react with water inside your red blood cells in the presence of an enzyme called carbonic anhydrase. Okay, there's the word. Okay, in the presence of an enzyme called carbonic anhydrase that's in your red cells. And we're going to form carbonic acid, H2CO3, which quickly dissociates into hydrogen ion. There should be a plus on there. And bicarbonate ion. Okay? So we're going to drive the reaction to the right. Yes?
Is this 2 equations?
No, it's a double arrow there. So this reaction goes to carbonic acid, which then dissociates and goes to hydrogen ion. And so it is 2 reactions, but it's really a continuous.
Okay.
Now, once we get back to the lungs and the CO2 levels drop, the reaction goes in reverse. Right? So we're going to get bicarbonate ion joined with hydrogen ion forming carbonic acid, dissociating into water and CO2. And so they're trying to show this reaction inside the red blood cells here. There's a couple of other pieces of information here that are important to us. The hydrogen ion that's released, some of it will join with the hemoglobin. And what did we just learn about hydrogen ion, acid, and unloading of oxygen. We learned that, right, as pH drops, O2 comes off more readily. So the hydrogen ion binds with hemoglobin and helps the unloading of the oxygen. Some of the hydrogen ion will also release into the plasma. The bicarbonate ion, HCO3 minus, diffuses out of the cells into the plasma. There's a negative charge on bicarbonate ion. As it leaves and takes a negative charge with it, we don't want to accumulate a charge across the red blood cell. So we need something to counter the movement of bicarbonate ion out. And the something that counters that is chloride ion. And the chloride ion will move in because it has a negative charge on it. It will balance that negative charge that came out. And that's sometimes called the chloride shift. All right, so bicarbonate ion has a negative charge, it's diffusing out. Chloride ion will diffuse in to try to counter that negative loss that's occurring. When you get back to the lungs, everything runs backwards. All right, so we're all going to run this in reverse. All right. Yes, exactly. Regulation of respiration. How do we regulate respiration? Okay? How do we regulate respiration? Well, it turns out that the nervous system plays a critical role, as one would expect, in regulating respiration. And we learned early in the course, when we were doing the nervous system, that the medulla oblongata has a respiratory system, and we learned that the pons has a respiratory part, right? There are respiratory centers in the pons. So the medulla is the cycling center for respiration. Okay? It's the cycling center. So it's the part that's going to say, turn on, turn off, turn on, turn off. When I was a young child, that's one of the things I said, gosh, how is it that I breathe when I'm sleeping? Right? I mean, it was because, unlike your heartbeat, which is just autonomic all the time, right? It's like, well, but I can control my respiration, right? But how come I don't stop breathing when I'm sleeping? Well, the medulla oblongata cycles on, off, on, off. Now, certainly we can control it, but it's turning the cycles on and off. There actually are some very strange nervous system abnormalities where the person loses the cycling from the medulla, and the person either has to consciously think about breathing or they have to be put on a respirator. Yes?
By cycles, do you mean like this, like during your sleep cycle?
No, not related to sleep cycles. A different cycle. It's just cycling all the time. You don't have to think about respiration right now, right?
Inhalation,
inhalation, exhalation. Inhalation, exhalation. Yes?
I stopped taking like Benadryl because when I would take it, it felt like I had to remember to breathe.
Yeah,
am I right?
I don't know a link there, but it could be histamine, right? Tends to depress the nervous system. So it may have been affecting your medulla. There may be a link there. I don't know about it. Yes?
Have they linked this to SIDS at all?
Have they linked it?
SIDS?
Not that I know of. So the best link that I've seen with SIDS is actually children sleeping on their abdomen and accumulation of carbon dioxide and depression of oxygen. But yes?
Is anything known about what's going on with that rhythmicity? You told us about the fast and slow channels in...
somebody has probably looked at that, what's happening there in terms of what's turning the on and off. I don't know, but somebody's probably figured, looked at it somewhere to say what is actually the cycling about. I don't know. The pons has two respiratory centers, the apneustic center and the pneumotaxic center. These two centers help to fine-tune your respirations. The apneustic center tends to be slightly, have a positive effect, and the pneumotaxic center has an inhibitory effect, right? So apneustic stimulatory, the pneumotaxic inhibitory. I look at these pons centers, folks, as kind of what happens when you have electronic watches these days. So you may not know this, but the electronic watches have a little crystal in them, and they're sending an electrical impulse through the crystal, and it cycles at a certain frequency. But the chances of that little crystal cycling at 1 second intervals, slim to none. So what they do is they have the electric charge go through that crystal, it generates a frequency, and then they fine-tune the frequency so that it's at 1 second intervals. Same thing here. So your medulla is turning on, turning off, turning on, turning off, and the pons, apneustic and pneumotaxic centers, adjust that. There is a interesting reflex involving the alveoli and some stretch receptors in the alveoli. It's called the Herring-Breuer reflex. The Herring-Breuer reflex. It doesn't play a very big role in humans, but it has a minor role. And so I should mention to you, this diagram's trying to show you this. In your alveoli, you have stretch receptors. And when you inhale very deeply, you stimulate the stretch receptors, and they'll send an impulse to the medulla saying, knock it off. All right? You've inhaled too deeply. Don't inhale anymore. Right? So a minor role in human respirations, but it still can play a role. So in very deep inhalations, the stretch receptors send an impulse to the medulla, inhibit the medulla so that you stop inhaling. All right, so this is the nervous system regulation. Now, what we really haven't talked about yet, though, is any kind of feedback loop. Right? So we said, yeah, the medulla cycles, pons has the apneustic and pneumotaxic, but we haven't linked it to a feedback loop. Well, I guess Herring-Breuer, right? But we haven't really linked it to a feedback loop. That's why we need to talk about chemical regulation of respiration. We need to look at the medulla oblongata and your aorta and carotid arteries. So some chemoreceptors. We talked about chemoreceptors when we were doing the nervous system. It turns out that your medulla oblongata has chemoreceptors that are sensitive to hydrogen ion. Okay, so they have chemoreceptors sensitive to hydrogen ion. So remember, the fourth ventricle is in the area of the medulla oblongata. Right? Kind of? Right? So that medulla is kind of forming the roof of that fourth ventricle. So the medulla oblongata has carbonic anhydrase, as does your red cells. What's carbonic anhydrase? That chemical that we said, right, that regulates the formation of carbonic acid. So CO2, H2. So in the cerebral spinal fluid that's in that fourth ventricle, as the hydrogen ion levels accumulate due to the presence of CO2, the hydrogen ion stimulates the medulla oblongata and tells you to breathe more rapidly. It tells you to breathe more rapidly.
Because the tissues are not getting enough oxygen?
No, because the hydrogen ion is accumulating. So, but you ask a good question. You know, when I first started taking anatomy physiology classes, I'd always assumed that if I held my breath, the reason that I would start breathing again is because my oxygen levels got too low. Right? It makes sense. I need oxygen. If O2 levels get low, that's what's going to make me stimulate my respiration. Not the case. In most cases, it's not the case. We'll find an exception in a minute. What stimulates respiration is accumulation of carbon dioxide and hydrogen ion. So if I asked you all to hold your breath, right? Take a deep breath, you hold it. Eventually, you're going to start breathing again, right? Oh, I got to breathe. Well, why? Because as carbon dioxide accumulates in the blood, right, and then in the cerebral spinal fluid, the medulla oblongata says, whoa, hydrogen ion levels are getting too high, meaning CO2 levels are getting too high. Right? There's that link that we looked at already, right? CO2 levels go up, hydrogen ion levels go up. You need to breathe because you've accumulated too much acid. Okay? So accumulation of hydrogen ion stimulates increased respiration. I grew up in the Sacramento Valley. If you've been in the Sacramento Valley much in the summertime, it gets really hot. Right? One of the things we learned as kids is you should always make friends with other kids that have swimming pools. Right? I mean, there was air conditioning, but not that much, right? So you made friends with people that had swimming pools, and so you'd go spend the whole day at your friends that had a swimming pool, right? And you'd play Marco Polo and other games. But one of the things that we would do is we would have a little contest to see who could swim the most laps underwater, right? And so we were taught by older kids that if you really wanted to hold your breath for a long time, you should stand on the side of the pool and hyperventilate, and you would supercharge your body with oxygen. And so we would stand there and we'd go, right? And then you'd take a deep breath and dive in, and you could swim a lot further underwater than you could before. And we thought, we're supercharging our body with oxygen. But what did we just learn about the saturation of hemoglobin at normal atmospheric pressures and oxygen? What did we learn? 100% saturated. Taking lots of breaths doesn't saturate your blood anymore with oxygen, it's still the same. So what were we doing? We were throwing out CO2. By hyperventilating, you can get rid of excess carbon dioxide. And if you get rid of excess carbon dioxide, you're going to raise the pH, right? Because you've gotten rid of hydrogen ion. You're going to fool your medulla oblongata into thinking, I don't have to breathe. There's no hydrogen ion around. And you can hold your breath for a longer period of time. Sometimes that's dangerous, right? There have been cases where people have died because they hold their breath underwater so long that the oxygen levels drop low enough that they go unconscious, right? And we, in fact, actually, in my small town that I grew up in, had a case where a young boy, he was 12 or 13, died that way. So he was just doing this in a doughboy swimming pool, above ground swimming pool. He didn't come up. Finally, the kids pulled him out, and he drowned, simply because he had held his breath too well. In those days, folks, I know this is hard to believe, but you couldn't dial 911. Right? You actually had to call the operator, and the operator would then call for the ambulance and whatever. So it can be dangerous. I'm not saying it's super dangerous, but it can be dangerous that you blow off so much CO2 that you can hold your breath for an exceptional long time. So the major stimulus for respiration is hydrogen ion. It turns out that we do have receptors for oxygen, so we have O2 receptors in the aorta and in the carotid arteries. Okay, so we do have, remember we talked about baroreceptors? These are near the baroreceptors. O2 receptors in the carotids and in the aorta that are sensitive to oxygen, but only if O2 levels get very low. That is, as O2 levels in the aorta and carotid arteries approach 40, they'll be stimulated. Now, wait a minute, didn't we just learn that an PO2 value of 40 is supposed to be found where? In the veins. Not in the pulmonary veins, in the systemic veins. So essentially what I'm telling you is if your O2 levels drop to what they're supposed to be only in the veins, these O2 receptors in the aorta and carotid arteries will sense the very low oxygen levels and stimulate the medulla. But only when PO2 levels get very low. When this happens, we say the person has switched to O2 drive. Right? They've switched to oxygen drive. Normally, right, it's hydrogen ion and CO2 that are telling you to breathe. But if your PO2 levels get very low, you can switch to an O2 drive that will force you to breathe when the oxygen levels are low enough. Yes?
Does that work by signaling the medulla?
It signals medulla, right? So these are impulses to the medulla, just like the baroreceptors, right? Same idea. Hopefully this doesn't happen very often now, but occasionally there have been reports, right, over the years of people in the hospital being killed by receiving oxygen. Right? The classic case would be Nurse Smith walks by the room and looks in at patient Miss Jones and says, oh, Miss Jones doesn't look very well today. Her color's really bad. She's having a hard time breathing. She's kind of bluish lips, right? Her color's really bad. I'll help her out. I'll give her some oxygen. So she goes in, puts little cannulas in her nose, turns up the oxygen full blast. Unbeknownst to Nurse Smith, Ms. Jones is working on oxygen drive. Because her respiratory system is functioning so poorly, The thing that's been making her breathe is the lack of oxygen, right? That's what's making her breathe. You now dose her with a high dose of oxygen, what's going to happen to respiratory rate? You've just killed Ms. Jones because the oxygen turns off the receptors in the aorta and the carotid arteries. Other factors that influence respiration, well, there's lots, right? So we can certainly mentally control respiration, right? I'm doing it when I'm talking, right? So that's a factor. If you dump cold water on a person, what happens? Right? So certain stimuli can affect the respiratory system. One of the, I think, we've been in this course, right? 3/4 of the semester here. And I think there's a tendency in here to say, well, we know all this about the body, there's not much else to know. There's plenty that we don't need, that we haven't learned yet. We do need to know, but we haven't learned yet, folks. There's lots and lots of stuff that we don't know. One of the really interesting things that we don't understand is why do you breathe rapidly when you're exercising? Say, well, why do I breathe rapidly when I'm exercising? Well, you might think, well, I need the oxygen, right? That's why I'm breathing rapidly. But if you check the PO2 and PCO2 levels in the venous blood and arterial blood, they're normal. That is, you're breathing fast enough when you're exercising to keep them at levels that are supposed to be. So what's the stimulus then? If they're already at level, right, normal levels, why are you breathing? So we really don't know why people breathe faster when they're exercising. There's some evidence that there's kind of a general accumulation of hydrogen ion in the body that may be a stimulus, but we don't really know. All right, let's stop there. So your quiz next week is on Wednesday. Respiratory system, we talked about regulation of respiration, right? We talked about Aaron-Royer, the medulla, chemical regulation, other factors. Now, we do have a quiz on Wednesday that will end with that material, right? So the material that we're going to cover right now will be on next Monday's quiz.
We didn't talk about the other factors.
Oh, we didn't talk about other factors? Yes, we did, right? Because I talked about that exercise affects respiration. I talked about throwing cold water on people. Those are the other factors that I wanted to put there.
Okay, you said those after you said it was the end of the quiz material.
So let's talk about some abnormalities of the respiratory system. Some of the things that can go wrong. One, of course, would be just failure of the respiratory system. If you quit breathing, you will die. What a surprise. You have 4 to 6 minutes to live if you quit breathing. The body obviously needs oxygen. You learned somewhere, I'm hoping, CPR, cardiopulmonary resuscitation, that involves both cardiac compressions and may involve artificial respiration. When you exhale air, there's plenty of oxygen left in what you exhale to help somebody that is not breathing. And so you can learn artificial respiration, just go on the internet, and it'll show you that you just have to pinch the person's nose, tilt the head back, and breathe for them. The cardio part of cardiopulmonary resuscitation requires chest compressions. You can't learn that on the internet. You need to take a class to get certified in CPR. You don't have time right now, but I would hope maybe if you're not certified already, maybe when class is over, excuse me, this summer, you would take the time to get certified. American Red Cross, American Heart Association, MPC, lots of different places offer CPR courses. Yes?
Does that expire, or do you...
It does expire. It does expire. But just because it's expired and you haven't repeated it, if somebody's laying there in front of you, go ahead and use it. You'll be protected by the Good Samaritan law, and so go ahead and do it anyway. Yes?
It's also required before you start nursing school at Hartnell.
All health professionals are going to require.
And you have to make sure that it's an American Heart Association certified one, not one that's just certified by the Red Cross.
So you need to be certified, folks. The reality is, 4 to 6 minutes is no time at all. If somebody collapsed in this room right now, I would suggest to you that if none of us knew CPR, we would not be able to get help here in 4 to 6 minutes. right? It's 4 to 6 minutes, goes very quickly. The person collapses, you have to realize they collapse, you have to realize they're not breathing, have no heart rate, then you have to call on the cell phone, then you have to try to remember where you're calling from. Then the ambulance has to come onto the campus and find us in this room. 4 minutes? I don't think so, right? It's not going to happen. So it's a good thing to do. Learn CPR, get certified, if not just for professional school, for your family, right? It's a good thing to know. Some other respiratory abnormalities, hypoxia. We know that means low amounts of oxygen. And we can actually break hypoxia down into a number of different types. Anemic hypoxia, that one's easy to figure out. You don't have enough red blood cells or enough hemoglobin. Ischemic hypoxia is occurring because you don't have enough blood flow to a particular area. Histotoxic hypoxia. Histo means what? What does histo mean? Tissues. You studied histology when you were in anatomy, right? So tissue toxic. So this means the tissues have been poisoned and are not able to use oxygen. There are certain poisons that stop the tissues from using oxygen. One of them, you don't need to know this, but is cyanide. So it stops your ability to use oxygen. And then a really kind of strange term, hypoxic hypoxia. Low oxygen, low oxygen. That's what, right? Hypoxia. So hypoxic hypoxia occurs when you have low amounts of oxygen coming into the respiratory system. So typically this would occur if you were suffocating, or would also occur if you were at high altitude, right? And so you get hypoxic hypoxia at high altitude. We talked a little bit about this the other day. At altitude, there's decreased partial pressures of oxygen, less O2 is available, and the body has many stresses that occur when that's the case. One of the things that's pretty interesting is that as the O2 levels start to get very low enough so that you start to go to oxygen drive, you will start to breathe more rapidly because of the low amounts of oxygen. And if you breathe more rapidly, what's going to happen to your CO2? It's going to go down, right? If you start hyperventilating, breathing too rapidly, your CO2 levels go down. And if those CO2 levels go down, they start to act as an unwanted brake on the increased respiration, right? Because if CO2 levels go down, hydrogen ion levels are going down, and that tells medulla you don't need to breathe. And so the brain has a hard time figuring out what to do at altitude. You start to breathe faster because of low oxygen, but you're blowing off too much CO2. So it's no, slow down those respirations. You can start to have acid-base balance imbalances, and we're going to talk about acid-base balance. So altitude sickness can be very serious, can be deadly. An abnormality called emphysema, that means literally to inflate. Most commonly caused by smoking, but there are other things that can damage the lungs. In this condition, the alveoli lose their elasticity. If the alveoli lose their elasticity, they don't snap back to push the air out, right? So you inflate, but there's no snapback to push the air back out. Major cause, as I said, is smoking. A condition called hyaline membrane disease has nothing to do with hyaline cartilage, except when they look at the lungs of these infants, their lungs look like hyaline cartilage. Remember looking at hyaline cartilage in anatomy? So this condition is a condition found primarily in premature infants. It's also sometimes called respiratory distress syndrome. When a fetus is developing, their lungs are one of the last tissues to fully develop because they don't need to breathe, right? They're not breathing. If they're born prematurely, the lungs may not have fully developed, and in the alveoli, the surfactant secreting cells have not yet become active in premature infants. Remember, surfactant lowers the surface tension. If you have high surface tension, the alveoli are kind of sticky, if you will. When that baby tries to take a breath, the alveoli are stuck together. It's really hard to pull them open. When the baby exhales, the alveoli tend to collapse, and then it has to try to pull them open. So respiration becomes a huge amount of work for these premature infants. One of the treatments is to put them on a respirator and force air into the alveoli to keep the alveoli inflated. When they do this, they call that treatment PEEP. It stands for positive end expiratory pressure, right? PEEP, positive end expiratory pressure, so that even when they're exhaling, there's positive pressure in there. This condition, the Hyaline membrane disease, used to kill thousands of premature infants each year. It has been dramatically reduced, the death rate, because 20 years ago, in 1993, an artificial surfactant was approved. You don't need to know the name of it. It's called ExoSurf. It's an artificial surfactant that can be sprayed into the lungs of these infants that keeps their alveoli from being, if you will, sticky. Right? So it lowers the surface tension. Interestingly, I think it's interesting, the man that discovered ExoSurf worked at UCSF. He was the same person that discovered surfactant clear back in the 1950s. So for 40-some years, he worked at developing an artificial surfactant to save premature infants' lives. Amazing, right? Didn't you hear stories like that? And now I've saved the best, or maybe the worst, for last here. Smoking. I don't know, which set of lungs would you like to have? So, smoking is incredibly irritating to the body, to the respiratory system, to the lungs. Tars and other substances accumulate in the lungs. You can get emphysema, you can get cancer. I have some statistics for you. You don't need to know these, but I'll just rattle off some statistics here for you. So in the United States now, there are about 400,000 deaths per year due to smoking. So that's more than 1,000 deaths a day that we can say are blamed on smoking. If you are a smoker, you will die about, on average, 15 years earlier than other people die. 60% of all smokers started before the age of 14, which is pretty amazing. This is an older statistic, but it's the last one I have. The advertising industry spends about $16 million a day on advertising cigarettes just in the United States. Of course, they've shifted a lot of their advertising overseas because we've become more restrictive here in the U.S. If you are a smoker, you have a 10 times increased risk of lung cancer and a 2 times increased risk of heart disease. Now, we know that when you hear 10 times risk of lung cancer, it sounds pretty scary, but we know that the major killer in the U.S. is heart disease. And so you have double the risk of heart disease. So as I said before, smokers are going to die of heart disease. There's some of them going to die of lung cancer. Of those that do get lung cancer, 9 out of 10 will die. So incredibly fatal. And smoking is the cause of 85% of both lung cancer and emphysema here in the U.S. Incredibly addictive drug, nicotine. 3 out of 4 people that stop smoking will start again within the year. That's equivalent or even a little worse than actually drugs, similar to drugs like heroin in terms of recidivism. So incredibly addictive drug. Secondhand smoke is always a risk. Here in the United States, we have 53,000 deaths a year that we can attribute to secondhand smoke. In 1993, so 20 years ago, the EPA categorized secondhand smoke as a Class A carcinogen. And what the heck's a Class A carcinogen? Class A carcinogens include asbestos and radon. Right? So when was the last time you asked somebody to come into your house and they said, gee, would you mind if I spread some asbestos around in your house? You would not let them spread it around. You'd say, step outside with your asbestos. Living with a smoker that smokes 1 pack a day, you have a 20% increased risk of developing lung cancer. If you spend an hour in a smoke-filled room, it's equivalent to having had 1 cigarette. Yes?
As far as, you said the EPA categorized secondhand smoke as a class what?
A, carcinogen.
Carcinogen, okay. Thank you.
Infants that are raised in a household where you have 1 pack a day smokers, you can find equivalent to 1 cigarette's worth a day of nicotine byproducts in their urine. So it's the same as handing that infant each day a cigarette, saying, well, have your daily cigarette, kid. It's good for you. Let's see. Females that take a birth control pill and smoke have a 10 times increased risk of heart disease and a 20 times increased risk of stroke. That's why we don't like women that use birth control or smoke to use birth control. And then I always like to appeal to vanity just a little bit here. We know that smoking causes facial wrinkles. You can sit professionals down and have them look at pictures of smokers and non-smokers, and they can pick out the smokers because smoking causes wrinkles. And we know that smoking contributes to impotence. So if you can't hit them with the other areas, right? And then the last thing I'll say, here in California, we're down to about 19% of the population smoking, which is really pretty good because at one time, clear back in the 1950s, we were around 50%. Eric?
I was just wondering, I've heard a lot of stuff around about what you could expect regeneratively if you quit smoking, and I was wondering if you knew anything about that.
Yeah, it's been a while since I looked at that statistic, but last time I looked, I believe that the insurance companies figure that somewhere between 7 to 10 years, your risk has come back to the average risk for the population. So that's probably the best that I can do. 7 to 10 years, you're back to an average risk. So I said 19% we're down to smoking. We've helped out a lot by changes in advertising, by not allowing people to smoke in bars and restaurants. The downside of the 19% is there are some researchers that feel that this is the lowest that you're going to get, that these are the hardcore addicts that cannot stop, right? So that there's some percentage of the population when they start a drug, they just can't give it up. And so they're concerned that this may be the lowest level that we may be able to get to. Carolyn?
Yeah, I have a question. Are we talking about the effects of nicotine or smoking?
Nicotine. Well, smoking nicotine, right? So studies on marijuana have not been, if that's where we're going, weed, whatever you want to call it.
I wasn't interested in what, but in my husband's in the military, and that's really popular, taking dip-to-view instead of smoking. So we're talking about the effects of nicotine.
So chewing tobacco, is that what you were saying?
Yeah.
Yeah. Well, that's a whole nother story because we're doing respiratory system here, but I mean, there's horrible, if you talk to dentists, and there's some good statistics that are out there for tongue cancer, gum cancer. It's really, really bad on those tissues and very addictive as well, the nicotine. Yes, Amelia?
I don't know if this is really true, but in Anatomy 5, we learned that nicotine has the same effects whether you smoke it or whether it's like the patch.
Oh, yeah. No. Yeah, nicotine's nicotine. I don't think that's correct, actually. So if you're using a patch or oral, you're not going to get the damage because it's not, I mean, look, right? I mean, what you're seeing there is accumulation of tar in the lungs. And that's not going to happen if you're using a patch or, but it's certainly, nicotine is an incredibly addictive drug. And maybe I guess I would finish here by saying, have some compassion for people that are smokers. Most smokers would like to quit, they can't, right? So have some compassion, but that that doesn't mean you have to let them smoke in your house or in your car. You can tell them to go outside. Okay, so let's finish that and move on to the urinary system.